Great, I think we can go ahead and get started. So good morning, good afternoon, and good evening from wherever you're joining us from. My name is Liz Colway, and I'm the Director of Community Building and Digital Engagement at the Sabin Vaccine Institute, which hosts the Boost community. I'd like to welcome everyone back on behalf of the Boost community and the World Health Organization to the 5th session of the COVID-19 for Immunization Programs Fellowship. And today we'll be covering vaccine hesitancy and demand. Before I get started, next slide, I'd like to just go through some logistics. So first, if you would prefer to listen to the session in French, we encourage you to select the interpretation button in the meeting controls at the bottom of your screen. You should see a globe icon. You can also see some instructions right on your computer or mobile device screen. Next slide. So during the session, you can engage in dialogue with your peers and session facilitators through our chat box. You can also use this forum to ask questions throughout the session. Once we get to the question and answer section, you may raise your hand to voice over your question, and that is if time permits. Finally, please remember to rename yourself. So first name, family name, and then country, so that we can record your attendance for today's session. Next slide. So this slide is just in response to the number of questions we've been getting regarding resources from previous sessions, including slide decks, as well as recordings in both English and French. So on your screen, you'll see that you can access all of those materials through the Boost Learning Group through the Resources tab. We'll upload all of these resources a few days after the session. We've also been sharing out the slides and recordings via email and through our Telegram channel as well. So really trying to meet you where you are. If you have any other questions or concerns, you can always email us at info@boostcommunity.org. Next slide. So today I'm joined by our session facilitator, Lisa Menning, who's the team lead of demand and behavioral sciences for the Essential Program on Immunization at the World Health Organization. Next slide. Before I hand things off to her, I'm just going to go over the agenda for today's session. So we'll again go over the strategic proposal and timeline. We'll reflect on some key takeaways from the last session, and then we'll again dive into the main topic for today, which is vaccine hesitancy and demand. Again, at the end of the session, we'll save some time for Q&A, so I do encourage you to share your questions in the chat throughout the presentation. Next slide. Over to you, Laura.
Thank you, Liz. Hi, everybody. Laura here. I just wanted to, I suppose, give a very quick overview of the proposal template, which you all should have received. So in the next slide, this is just providing some key highlights of what we want and what we're expecting. So as part of the template, there are clear instructions of how to complete each section. And we're really hoping that you will consider that these responses should be well supported with data and other resources. The proposal is around 2,500 words, that's the expectation. And the deadline, I think many people have been requesting the deadline, is to submit by July 1st. So we hope that you will have begun working on your proposal. And once they're submitted, then these will all be reviewed by experts and feedback will be provided. So I think that's kind of a general highlight I wanted to provide to you today. And in the next slide, we actually have a poll question. And we want to know, have you started your strategic proposal yet? So if you want to open the poll and see, start responding, have you started your strategic proposal yet? So you can start answering this. So we'll give you a few minutes, or we'll give you about a minute. So it seems like quite a lot of you have not yet. And I think as you consider beginning your strategic proposal, really consider what is going to be presented today and also what's been presented in the previous sessions over the past couple of weeks, because I think taking that into consideration will really help with thinking through what is the most appropriate way to go about your strategic proposal and which strategies will be best placed to help you with COVID-19 recovery. So we can see that most of you have, over two-thirds of you have not yet started. So I think given that, it'll be great if you could just go piece by piece or section by section through the template, review it, see where things are possible for you to incorporate or not, and then as time goes on, it'll help you to be more advanced in your planning, so you're not doing it at the end of the the last deadline. Okay, so thank you very much, and over to you, Liz.
Wonderful. Thanks so much, Laura. And I know we've been getting a few questions in the chat. We will share out the link to the template both in English and French. Please note that we will have submission instructions available in the next couple weeks. So we provided the template so that you can draft your strategic proposal or case study, but then there will be separate instructions for submitting that proposal by the deadline of July 1st. So again, that'll be communicated through the next session as well as through email too. Next slide. Great, so thanks to everyone who posted on the Learning Group forum last week in response to the question, what are the data gaps, data availability and quality, transforming data into insights, or motivation, capacity, and empowerment to act on evidence? On the next slide, we've showcased some of your responses. There were several more again in the forum, so I do encourage you to check that out. And you can see, I won't read through all the responses, but for an example, Dr. Adora mentioned that today numbers rule the world because we cannot evaluate programs and policies that bring about development without numbers. Good data combined with knowledge and experience and augmented by new technologies have the capacity to transform the development process. They document successes, bear witness to failures, and throw light on complex problems. And they give governments and citizens the information needed to make decisions and control their own development. So thanks again to all those who answered those questions. Again, we'll have a reflection question this week as well, which we'll pose at the end of the session. With that, if you could move to the next slide, please. I'm going to actually hand it back over to Laura, who's just going to go over some key takeaways from last week's session. Over to you, Laura.
Thanks, Liz. So last week, it was a very engaging session. I think a lot of you were very active in the chat and participating and shared a lot of interest in what Jan and Carolina presented. So we looked at using immunization data for action. And on the next slide were kind of some of the key takeaways and discussion points that came up during the session. It was evident based on a lot of the information that Jan provided that the COVID-19 pandemic has impacted our immunization program implementation, and it has also impacted the coverage and surveillance of vaccine preventable diseases. So I think this is, I suppose, a very good stepping stone for the background as to why many of us are concerned about the recovery for COVID-19. Given the impact that this has had on our programs. Also, Carolina presented on the benefits and risks, or the advantages and disadvantages of administrative and survey methods, and how best to estimate vaccination coverage. There's a lot of interest from people regarding electronic immunization registries, which I think is certainly something that we're going to see happening more in the future. But there's a lot of it takes time to implement these systems, and it just requires a lot of resources, but they do have advantages in that they can provide more detailed follow-up of individuals. And then finally, Jan also presented to us on the data triangulation, which is an important tool or methodology for bringing together data and analyzing it more critically. So it was a really great session last week, and I hope that you can keep the same engagement for this session that we're having with Lisa today. And then in the next slide, Jan presented this slide, which kind of shows some data that might be useful or guide you through the recovery. So kind of looking at what the capacity is for human resources, looking at what are the numbers of outreach sessions that are held versus what was planned, the demand and social data, which is great that we have Lisa today because we have a dedicated webinar on this today. And then we also talked about numerators, survey data, coverage, and emergent vaccine preventable disease cases. So it's good to look and track all those data because that can have great implications on your immunization program.
Great, and I think we'll hand things over to Lisa then. Over to you, Lisa.
Okay, thank you so much, Liz and Laura, and it's really a pleasure to join you all today for this session. I'm just starting screen sharing now to be able to go through my slides. So in this presentation, I'm going to be talking about what drives vaccine uptake and thinking about the behavioural and social drivers specifically, and ways in which we need to be gathering data to learn more about the reasons why there's low uptake, and from there to design tailored and targeted strategies. So in the first part of my presentation, I'll be talking about what drives vaccine uptake and what we should be measuring and how we can measure that to have these insights about these reasons for low uptake. And in the second main part of my presentation, I'll be talking about specific areas of intervention that can be matched to certain barriers or drivers that we identify. And I'll also talk specifically about hesitancy as well. So just to dive in, when we hear people talking about why there's low uptake or why we have low coverage of certain vaccines, we often hear this narrative that focuses on anti-vaxxers and people who are refusing vaccination and the role of misinformation in that as well. So there's generally a very simple model or a simple narrative that's used to explain low coverage and therefore the outbreaks. And it essentially refers to this idea that there are anti-vaxxers or people who refuse vaccines or might be hesitant, and therefore there's a decline in acceptance and confidence, which therefore impacts coverage. We have low coverage, we have gaps in uptake, and therefore this leads to outbreaks. And this is the simple explanation that's often given for why we have low coverage and outbreaks. But based on the work of a WHO expert group, with the involvement of many partners from around the world and many experts from various disciplines in different parts of the world, we have drawn on global evidence to put together this framework, which shows these four main behavioural and social drivers which determine vaccination uptake. And these four drivers are thinking and feeling. And this is about people's confidence and their attitudes and beliefs. And so this is where we situate people's perceptions around the benefits of vaccination or safety, and also trust in vaccines and authorities as well. Secondly, there are the social processes or social influences, including social norms. This could be situated in a family, in a peer group or a community, and also includes a recommendation of a health worker towards vaccination, and also gender and equity related barriers as well. And typically these two factors or domains contribute to influencing motivations. And motivations are people's intentions or willingness to want to get the recommended vaccines. And importantly, this is where we situate hesitancy. And I'll talk more about hesitancy later in the presentation. And lastly, there are these practical issues or practical factors which really relate to the various dimensions of access and availability and affordability of vaccination. And this includes the various elements of what it takes for someone to actually get to a point of service, to a vaccination clinic, as well as their experience or satisfaction on site during that vaccination visit, and even also just what happens just afterwards. So mainly based on a lot of the data that we have analysed in recent years, the main barriers, generally speaking, are situated related to the practical issues. This is where the main barriers or drivers are that we see for most programs around the world. And we have then used this framework as a basis for developing a series of survey tools for qualitative for quantitative data, as well as interview guides to enable us to gather qualitative data as well that give us a deeper understanding of all of these issues. And we have these tools available for COVID vaccines and childhood vaccination as well. So just to elaborate on these tools, like I said, for childhood and COVID vaccination, we have a survey tool with about 20 items or 20 questions in each survey. And then the qualitative tools, like I said, that give us a deeper understanding and enable us to have a semi-structured discussion to really go into more detail on certain barriers and drivers, specifically for certain targeted population groups. And to help with the use of these tools, we have developed a very practical and a step-by-step user guide that goes through the key steps to gathering and using this data. So all of the tools and guidance are available at this link. And it's also important to note that with our expert group, we have gone through an incredibly robust process of field testing and validating these tools as well. So in many, many countries all around the world, in Africa, the Middle East and Asia, in the US and Australia, we went through a very intensive process of testing and validating these tools so that we're really sure that they are measuring exactly the right questions, and the questions themselves are designed to be as simple and straightforward and usable and translatable as possible. So why is it important for us to measure BEVs, or these behavioral and social drivers of vaccination? These give us critical insights into understanding the reasons why there's low uptake of any vaccine for any population. Often in designing and implementing immunization programs, we often know where coverage is low, where there might be disease outbreaks. We know where there might be stockouts or where there's good supply available, but we don't always zoom in to focus on specific population groups and really ask why, and systematically gather data in a very structured way that also enables us to compare this data later in time or between different locations. So these tools enable us to have a very systematic and structured basis for understanding these exact reasons. And this data can then be used to track trends, to measure interventions, to find out if the activities that we're implementing are actually effective. So all of this work around measuring why there's low uptake and then measuring the effectiveness of our interventions is critical for being able to plan our programs, design policies, and think about where we can best allocate sometimes our limited resources in our program. And having this data available can be then shared with partners, other collaborators, civil society, NGOs, many others, to be very clear and transparent in communicating why there are these gaps and what to do about it. The data can also be used to guide training and other types of strategies that build the capacity and enhance the contribution of many other stakeholders that support the design and implementation of the immunization program as well. And importantly as well, we will be connecting these indicators that are based on our tools. We have identified priority indicators, which are just 5 key questions for routine tracking, and these are connected to IA 2030 and strategic priority number 2 on commitment and demand, so that we then at a country level, regional and global level are all tracking and measuring on some of the same indicators as well. So let's just take a quick look in a little more detail at what we're exactly measuring. So I showed you the framework with the 4 domains. that are thinking and feeling, motivation, social processes, and these practical issues. And we also have a range of demographic questions as well that enable us to understand a little bit more, in this case, about the child or infant being vaccinated, but also about the parent themselves or the caregiver. And here you can see, for example, that each box here refers to a different question in our survey. And the ones shown in red correspond to our priority question or our priority indicators, which are the ones we are recommending for most systematic, consistent measurement over time and between different settings. So as you can see in the thinking and feeling domain, in that left-hand column, in addition to measuring confidence in the benefits of the vaccine, we're also measuring confidence in vaccine safety and in the health workers as well, which is related to trust in the health worker. And for example, in the social processes column in green, we can also see these other social influences we're measuring, the norms at a family or peer level, norms or influences from a community leader or a religious leader, for example. And this is just to give a more comprehensive overview of each of the topics or constructs that we have in the survey that correspond to these different themes. So I've mentioned the priority indicators, and these are the questions that we identified in our testing and validation process that performed the best. And I can explain why if needed, if anyone has any questions. But these are really the most meaningful, important questions to be asking. And I'm not going to read out exactly all the details here on the questions, but it's just to give an example of what they look like for childhood vaccination and to show the questions in the middle column and then the corresponding indicators on the right-hand side. So for example, in the last two rows here, the practical issues, knowing where to get vaccinated. Do you know where to go to get your child vaccinated? And the corresponding indicator is the percentage of parents or caregivers who know where to go. And so this just gives you a sense of the flavor for the simplicity of our questions. So they're very easy to use and to integrate into other data collection activities if needed, and the kind of indicator that we would be measuring over time and between different locations. So here's just a quick snapshot of data that we have gathered from Nigeria. It's a high-level summary just for our 5 priority indicators, and this is for childhood vaccination, and we can see here a comparison between male versus female respondents. And here on the right-hand side, I'm specifically highlighting the domains or indicators in the practical issues domain. And this is where we found the most barriers towards uptake, the biggest issues. So knowing where to get vaccinated was lower for males compared to females. And this is mainly because, could be explained because the mother has the main responsibility for taking the children to get vaccinated in this setting. But then maybe there are some other questions to be asked about whether the mother has the autonomy and needs to get permission to be out. Can she afford to do that? And this is the next question here. So even for males and females, do they say that vaccination is moderately or very easy to pay for? And this appears to be perhaps one of the biggest barriers here, that affordability is quite low. And this includes also some of the costs associated with getting to the health facility as well. Those out-of-pocket costs in maybe paying for a bus ticket or the cost of having to take a day off work to take your children for vaccination. So it's just to give you an example of how the findings might look and therefore what it can lead us towards for further actions. So how do we use these tools for gathering and using local data? this is really critical and cannot be done alone in many various ways. So just to summarize some of the key steps here to give you an idea of how to get started. So firstly, just thinking about who you need to be working with to gather this data using these tools. So thinking about what are the stakeholders and partners, and the need to identify, maybe in some cases, a specialist local research partner, maybe at a university or a market research company. Then there's some steps after that in thinking about what tools to be using, what data is already available, what do you already know, for what population do we have the biggest questions and information gaps, where do we have lowest coverage in your country or different district or region, and these kinds of considerations enable us to then decide what tools do we need to use. Is it the survey or the interview guides for qualitative? And we then start to refine the plan and then think about, okay, here's my population, here are my main needs and questions, here are the tools I'm going to use. Now let's develop a plan. When are we going to do this? How much will it cost? Who's going to do the data collection and analysis? And then after that, even start thinking about how that data will be used and who needs to be involved from the beginning. So they're also involved in some of these planning steps as well. And maybe it's also really important to think about including or integrating these priority indicator questions into existing data collection processes. So sometimes in some settings, programs have routine data collection for the immunization program on coverage or surveillance data, or just simply the number of children getting vaccinated or that are missed. And as part of that, it might be an opportunity to also ask some of our priority questions. And lastly, after there's discussions that take place about use of the data, thinking about those interventions that will be tailored and targeted to a specific population, and how these tools can also help in some ongoing measurement or monitoring to really help understand if those interventions are being effective and giving us the improvements in coverage and uptake that we might expect to see. And this helps to guide us towards gradual little improvements and enhancements to our interventions and activities that can be informed by this data. So at this point, I've so far described the tools that we have available and what we need to be measuring, not only people's thinking, feeling, the attitudes, beliefs, and confidence, but these social influences, motivation, and also the practical factors. So talked about what we measure, how we measure that, and how we can start to think ahead about how the data is used for monitoring and evaluation as well. But this is not just about the data. There's a lot to be said for using knowledge and evidence to decide which interventions are going to be most effective in addressing the problems we face. And before I get into more detail about what works to increase vaccine uptake, I want to take a moment here to talk about a principle related to behavioral and social sciences, which is really about a foundational concept and understanding we have from the evidence about what shapes actual health behaviors and vaccination behaviors as well. And the point here to be made is that knowledge does not always correspond to behaviors. So what I'm going to do here is see if it works to try an interactive exercise. So I'm going to ask a question to everyone here and ask you to raise your hand if you would answer yes to this question. So the question is, do you know that it is important to exercise maybe twice a week. Once, but maybe probably more twice a hand, but maybe even 3 times a week. Do you know that it's important to do regular exercise in our day-to-day life? Put your hand up using the raise hand feature if you know that it's important to do regular exercise. So I'm seeing a lot of hands go up quickly. There's about 60, 70 hands already up. So raise your hand if you know we should do regular exercise, at least maybe 2 or 3 times a week. And you know, this can be any kind of exercise as well. Going for a bit of a walk, maybe jogging, swimming, playing football, riding a bike. This is something that really gets us being active. And this is really a part of a general health behavior that we should not be too sedentary. So I've seen a lot of hands go up. So it looks like many people here we know that it's important that we should be doing regular exercise. Okay, so stop there. We have about 90 hands, I think, that went up. Now, put your hand down if you do not exercise this regularly. Take your hand down now if you do not exercise as much as we know that we should. So what you should be doing is actually keeping your hand up if you know that we should regularly exercise. So we've maybe lost there's been about half of the group that put their hands up who've taken their hands down now. So it's just a way of illustrating, using Zoom here, to illustrating the point that we know we should exercise. We know we should eat a healthy diet. There's all this knowledge we have about our behaviors and how we should live a healthy life. But because of our day-to-day life and the way in which we have many other competing priorities in life, it's just not always an easy thing to do. It's not always convenient. Maybe other things get in the way. And it's to illustrate that we know that exercising is important. We plan maybe to exercise. Like, for example, I set my alarm most days to get up early and go for a walk. But sometimes I go to bed late because I'm working. So there's all these reasons why there are problems that get in the way in day-to-day life that prevent us from doing these healthy behaviors and healthy actions that we know is necessary. So all of this to say and to try to illustrate that we know certain things about behaviors and our health behaviors. We know that we should vaccinate our children. Most parents know that vaccination is important, but whether they actually plan to carry out that behavior, and even then, whether they're able to actually carry it out, depends on so many different factors in this world. And that's why it's really important to measure across these different domains that I described. Okay, so let's move on now and talk then about what these interventions we know that are effective based on global evidence and expertise, and how we need to respond to actually thinking about behaviors, because this is the end result that we're really truly trying to shape. So based on the work with our expert group over the last few years, in addition to developing those tools, we did an evidence review, a scoping review, and based on identifying and all the systematic reviews and meta-analyses, we identified a range of interventions that are shown to increase vaccination and have mapped them out to correspond to the different domains or problems or the barriers where there's that explain why there's low uptake in different settings. So, for example, looking at this last row here to address the practical issues, there's a lot of evidence which shows that interventions like reducing out-of-pocket costs or improving service quality or sending an SMS to remind someone simply don't forget that you need to take your child for vaccination tomorrow, or you missed your dose. Don't forget to come back anytime in the next few days. All of these little kinds of interventions approach this from a little more of a behavioral standpoint that helps to make it much easier for people, more convenient for people to take their children for vaccination or even to get vaccinated themselves. So there's a lot more to be said on these interventions, but this is just to illustrate the range of options that we have that really go beyond thinking that more information and education or more social mobilization is needed. We need to think about what actually contributes to shaping behaviors, because this is where we will get the most impact in our interventions. And these interventions can be grouped mainly into 4 different categories. And this is also to help simplify the planning process and also make this memorable as well. So this is our tree of interventions, and it basically describes these 4 main groupings. Firstly, thinking about the quality and accessibility of services. Secondly, working with trusted community champions. And it's really important that we work with local community leaders or representatives who are trusted, who can also promote vaccination and help in linking parents or others to vaccination services and joining people in that community to those services. Then, of course, information is still important. We still want to be able to provide accurate, trusted information available, make that easily available, and also think about the structures and policies, which can also address certain inequities and certain gaps and provide those other different types of supportive ways of making vaccination a default and a commonly done act that we should all do for our children and ourselves. And to do all of these 4 main areas of intervention, there are 3 other things that are determinants in a way, contribute to our ability to implement those 4 types of interventions. That is generally having political commitment. We know that to do a lot of this work requires the investment and words and actions of our political leaders and decision makers. That's really important. And there can be a lot more to be said on that as well. We also need a really strong, capable and motivated health workforce who are well trained and well supported to be delivering good services and that good experience as well. And lastly, there's the behavioral data. So our data on the behavioral and social drivers, which enables us to understand why there's low uptake, to diagnose those problems, and then enable us to measure our interventions to know if they're effective in specific contexts. So there's a real critical importance here on quality immunization services and ensuring that immunization services truly meet the needs of the communities that they're intended to serve. And so here on the right-hand side of this slide are 7 guiding principles of quality. What is quality when it comes down to when we talk about vaccination services? And quality is they're effective, safe, people-centered, timely, and integrated and equitable, these kinds of factors. And so based on this and all available evidence about designing services that are quality and really truly meet community needs, we've developed this brief planning guide to bring together all of this knowledge and make it very actionable as well. Lay it out in very straightforward steps to help decision makers and program planners and implementers in implementing all of this as well. And here's a link to this guide at the end of the slide. So I'm going to pause here for a second just to ask this question. How can having an understanding of behavioral and social drivers help with recovery? How will having such data available on these factors give us a better understanding of what we need to do to recover and enhance and close those gaps in our immunization programs that have accumulated over the last couple of years. This is just a question for you to think about and to respond to in the chat. So for now, if you have any answers to this question about how understanding behavioral and social drivers, how we need to understand these reasons for low uptake will help us with the recovery effort. So we can discuss this later in the webinar, or if you have any thoughts already to answer this question, please put that in the chat function. So in the next few slides, I'm just going to briefly talk about vaccine hesitancy. And hesitancy is not always the main reason for low uptake, but it's often spoken about a lot. And there's a lot of attention on hesitancy in some settings to explain why there's low uptake. So what is hesitancy? Hesitancy is part of this motivation domain. So it's only really one of these four main domains or four main drivers of vaccine uptake. And it's defined as a motivational state. There's someone who would be conflicted about or opposed to getting vaccinated. You know, they're not really entirely sure. They're maybe undecided on the fence. And this includes whether someone is intending to get vaccinated or their willingness. Are they really kind of thinking ahead and planning they want to get vaccinated or vaccinate their child? So it's this motivational state. And understanding this very clearly is important to then being able to say, okay, where do we have our hesitant population groups? And then what do we need to do to understand more about why they're hesitant, and then how to design some tailored and targeted strategies to respond. And hesitancy normally can be also situated on this continuum. So this curve is going to be very context specific. It's not to scale at all, but it's just to illustrate where these intentions are situated on this continuum. And basically on the far left side, we have those who are most opposing and rejecting vaccination, a very, very small minority in most countries. And on the far right-hand side, we've got those who really support and strongly advocate and champion vaccination, or those parents who would really demand and want to seek and actively support vaccination as well. And the majority of people will just accept vaccination and want to get vaccination. They know it's the norm, it's the right thing to do. But also here on our left-hand side, we have a small hesitant group as well. Now, what do we do about this? And we know the hesitant group, like I said, they might have some questions or concerns. They're undecided. Maybe they're going to wait for a bit more information, or they're going to wait and see what other people around them would be planning to do. How do we respond? The first thing to do is to not say anything, to not do anything, just to listen and to really say, okay, tell me why you're concerned. Why are you undecided? Tell me more about that. And to have a very open and very respectful and caring conversation to really help, this person talk about their underlying concerns and worries and what might be holding them back. And from there, we can get an understanding of why they might feel this way, and then we can start to respond. But it's really important to do this listening. Listening can be, in a way, an intervention itself to really help someone feel like their concerns are simply heard and acknowledged. And this alone can make a difference. And then as needed, we can respond and share more information, and we can maybe refer them to someone else that we know who can give them more details. It might be helpful for them to talk to a religious leader or another doctor or another expert. So go as far as we can, and then maybe think about whether that has addressed the problem, the questions they had, or whether we need to find a way of continuing the conversation. So how to talk about vaccines? Often in our day-to-day life, we often come across people who say, look, I'm really just not that sure. I'm going to wait a little bit, or I want a bit more information, or no, I'm not really sure about this. I don't think I'm going to get vaccinated. So like I said, how do we have these conversations? And this is particularly important for health workers to have these kinds of skills, because they're at the front line, they're at the community, often being faced with parents or others who are not sure, and how they demonstrate that they care and want to listen and want to help that person to move towards a decision towards accepting vaccination is really important. So like I said, listen, be caring, share information where you can, maybe go a little bit further to ask follow-up questions, say things like, well, tell me a little bit more about why you feel that way, or what's holding you back. What else would help? And then always recommend vaccination. If there's a point that you get to where the conversation is starting to close and resolve, always recommend vaccination. And there's no need to do this in a forceful way. We know that it's supported by decades of science and evidence, this global consensus. So we can, with confidence, still recommend vaccination as the right thing to do, and do that in a supportive way. And then find ways to, like I said, refer them to someone for more information, or find other ways to continue it and maybe touch base again. And then also, there are different ways in which organizations, civil society, NGOs, local associations, faith-based organizations can also help with this by leading by example, promoting vaccination, showing that their leadership is vaccinated, that everyone there gets vaccinated, or that vaccination can be available on site where they work, making it so easy. So all of these different ways in which local organizations can show that they support vaccination and they promote it. It's the right thing to do, and to do that also in a supportive, trusting, caring and respectful way. And this helps to also build and demonstrate those norms. Now, going to say a couple of things about misinformation, because there has been a lot of misinformation over the last couple of years about COVID vaccines. COVID, as we know, has been so new. We've never heard about it before. All of the knowledge and evidence and science about COVID and COVID vaccines has been changing so rapidly, and more new knowledge available over time in recent months and years. So this has been a very rapidly changing information environment. And it means that people have tried to answer these questions and explain, what is happening, and explain the vaccines, and the vaccines were developed rapidly, and there are many good answers to explain that. But at the same time, there's been rumors and misinformation as people have tried to help answer some of these questions. And there's been also people in some very rare cases, deliberately spreading misinformation as well. So what do we need to do about this in immunization programs? So here are some steps to help us to know if we need to respond. So we need to, again, be listening and monitoring, and be doing media monitoring, and also with colleagues, monitoring social media and digital media as well. And really understand, okay, who is being exposed to this misinformation? Who is seeing it? Who's hearing it? And then, is it actually changing behavior? Is there a decline in vaccination rates? Is there a decline in people wanting to get vaccinated, in motivations towards vaccination? So how is it affecting these domains that I described? Next, how far is the misinformation spreading? Is it just a little small bubble? Is it just a small group of people? Or is it everywhere? Is everyone exposed to this misinformation? And after that, we can then start to build a response. And we may warn people, we may want to share accurate information to address those rumors and misinformation. And what we might need to do sometimes is to prepare people and say, you might hear rumors that people are saying that there are bad ingredients in COVID vaccines. And then you follow up with accurate information. And then you can say, but we know that these vaccines have been developed through a robust process. They've been thoroughly tested and evaluation and start to elaborate on why we know that vaccines are safe and effective. So we say to people, you might have heard about this, and here's the correct information. And often it's really important to work through trusted community leaders, other trusted organizations and partners in sharing accurate information, because sometimes the people who are sharing accurate information, the messenger is sometimes more important than the messenger, than the message itself. And also sometimes there are people, like I said, who are deliberately spreading misinformation because they might have something to gain from that. And the important thing is to find out who is spreading the misinformation, and based on that, figure out if or how to respond to them as well. And sometimes people are doing this because they want attention, they want a response, they're creating oxygen. So it's really important that we sometimes, for some of these people who are the source of misinformation, to not respond to them and to ignore them as well. So here are some steps on how to stop the spread of misinformation. And it illustrates how there can be this cascade that we can actually avoid this amplification of misinformation by helping ensure that people know how to double check the source of the information that they're seeing, and that they can check the facts as well. And this is just an easy few steps to take to help make sure that people are aware of how to check their facts, check their sources, and to not continue sharing that information if they are not sure about its accuracy or where it comes from. And there's a WHO document here on our website that has more detail on these kinds of steps. Now, debunking or responding to misinformation or correcting misinformation is also absolutely critical. Sometimes it's really important to do this as well. And like I said earlier on, knowledge and information is important. We want to make sure that people have answers to their questions if they're curious and need more information to help move them towards vaccination. But having knowledge alone is not going to be enough for that vaccination behavior. So here's how we address misinformation. What we need to do is start with the fact. Say, vaccines contain safe ingredients. And then we continue with a warning. However, people are maybe sharing misinformation about bad ingredients in vaccines. And then say, maybe it's possible that something was misinterpreted, but here's what we know, and to maybe elaborate a little bit more about, all of the knowledge and evidence we have about the vaccine manufacturing, research and development process, and then also end with the fact again, that we know that vaccines are safe, they contain safe and thoroughly tested ingredients, and here's therefore how to basically start with the fact, correct the misinformation, and finish with the fact again. And an easy way of remembering this is referring to this as a truth sandwich, because on either side, the bread is the facts, and in the middle, we have this little warning about the misinformation. So you can remember this by referring to it as your truth sandwich. So here's just another brief example of what this could look like. Firstly, saying that the COVID vaccine will not make you sick with COVID. But we've seen misinformation And in some cases, people have said, or there have been rumors that the vaccine could actually give you COVID. And this is not true. And in fact, maybe sometimes people will feel unwell after getting vaccinated because it's normal. We might have a fever or even just a bit of a sore arm after getting vaccinated. And that's a sign the vaccine's working and it's building our immunity. So then we can then finish with the fact again and basically reinforce this message saying a vaccine cannot make you sick with COVID. And sometimes there will be a mild or moderate side effect. And this is really just your immune system learning how to recognize and respond to the virus. And sometimes that causes a fever. So again, you see this example of the way in which we provide the fact, we address the misinformation in the middle, and then we come back and reinforce the fact again at the end. And sometimes this is really important in certain cases where we want to really think ahead and make sure this information is easily available. Now, sometimes in certain settings, we do have hesitancy. It's rarely the main reason why there's low uptake, but it does exist in some specific communities or populations. So how do we respond? And often programs not only might have hesitancy, but they might have other districts or communities with low uptake. And we don't even know yet why there's low uptake there. We might not have great data yet available to really explain the root causes why there's low uptake for a certain population group. So we have also developed this guide. It's called Closing Gaps. It's a human-centered design approach for tailoring immunization programs. And it's a very community-centered process for, at a very local level, understanding these exact reasons, diagnosing the low uptake, and then co-designing the services or interventions or any kind of strategy to meet those local needs and problems. So it's really important in that it does this together with representatives of the community themselves, because often the community members also have the best knowledge about possible solutions, and we want them to be involved and part of the process in either helping to identify the solutions or design and implement those solutions. So we work together with certain community representatives there and make it very inclusive and step-by-step, very practical, data-driven. And this approach is also very user-friendly, practical, and adaptable. So it's truly designed to be used in a district or in a community or even a village, for example, at a local level where we know we have very low uptake. And it takes us through this step-by-step process, starting with the diagnosis. And this uses our BESD tools for behavioral and social drivers with the 4 domains. So we start by diagnosing, then co-designing the right kinds of solutions or strategies, and then we implement and evaluate. And this can be a very small step-by-step process. So it doesn't even really require that we spend months perfecting the right kind of, specialized strategy. All we can do is pilot something that's very small and simple. As long as we're doing some basic monitoring and evaluation, we're able to get up and running and started and take some steps in the right direction with the right local partners. And the closing gaps for HCD tip approach is, like I said, designed across these 4 main steps. And it's super useful in the way it's designed is very practical and organized by 4 main areas. The objective of each step, we then see certain activities, the tools that are used as part of that process, and then the questions that are answered in each step. So as you can see, for each of the 4 main steps, we break it down into also 4 main types of actions to take place in each step. so that it's very useful and stepwise, and it comes with lots of templates and tools to make each of these things really easy for people at a local level, and just to help in getting people up and running and give them a head start in what to do. And here's an example of what this might look like in a local setting. So here's Sarah, and her children are not vaccinated. And we can have a variety of different, assumptions or thoughts about the reason why Sarah's children are not vaccinated. Maybe, and I'm not going to read out all of these different reasons, but you can see that there's a wide range of reasons that can be these possibilities. Maybe she doesn't believe that measles is serious enough. Maybe she has concerns about the side effects of the vaccine. Maybe she has heard from her sister or other friends that it's just too far to go. And when you get there, it's really crowded. You have to wait a long time, and she's kind of been thinking that she should go, but she just never really got around to it. And maybe there's also a little bit of, questions and resistance in the community. Maybe there's a religious leader who doesn't support vaccination as well. So as you can see, in a certain setting, there can be a very diverse mix of these different reasons why there's low uptake in this setting, or why Sarah is not vaccinating her children. So what do we do about this? And based on the tools and the domains that I've described, we can start to narrow this down. So, for example, based on the tools that I've described, we might be able to then have a sharper, more specific understanding that, in fact, her children are not vaccinated because she's really just not sure when to go, what doses are offered when, and maybe what they prevent, what diseases they prevent against. Or she received some pamphlet and there was a picture on it of all these men, and she just, or maybe there were other pictures of it that really were just not culturally appropriate for her. Or maybe there were other photos that she was just not really comfortable with, and that made her just a bit reluctant. It just didn't feel appropriate for her. So once we have a better understanding that those are the problems, we're able to design and evaluate these targeted strategies. So maybe we need better information materials, or maybe we need to make sure we're sharing that information through the channels or sources that she knows and trusts. Another example is actually we do some further investigation, and then we realize that actually she doesn't really trust the government authorities, and there are religious leaders in her village who also have some concerns about vaccination. So when we have a better understanding that this is the problem, we're able to then think about cultural awareness training, or finding mediators who, health workers or community health workers who can really reach out to Sarah and respond to some of her questions and concerns. Or maybe there are just some people, community leaders or community representatives, traditional leaders in her setting, in her community, who just need to speak a little more actively about the importance and benefits of vaccination and reinforce that it's the norm, it's a good, trusted thing to do. But the next thing is that maybe we address all of those questions and concerns. We actually know that we're getting the right information to her. We know that the community is now supportive. We've engaged the religious leaders, we've engaged the community health workers, and they're now doing a really good job of promoting vaccination. Still, nothing's happening. We're not seeing an increase in coverage. And this is where our data from the beginning needs to give us good answers. And this is where we can see that maybe actually the biggest problem here that Sarah's facing is that, the hours are just not too convenient. She doesn't want to go, it's too far, all these other things that I described. So maybe in the end, the best solution is to think about bringing services closer to her, to her street, to where she lives, maybe to the local childcare centre. Maybe there's a local community centre where a lot of the women gather together regularly throughout the week. Maybe there's a need to change the timings or offer more vaccination services. So there are many other solutions, but it just gives you an idea of the different kinds of steps and the process to go through, and also ways in which the data that we gather to diagnose these problems need to be thorough and comprehensive, and also that we need to prioritize the interventions that will be most effective in addressing the barriers as well. So matching the reasons for low uptake with the right solution is always absolutely critical. So just to start to summarize here, what's needed to achieve high uptake of any vaccine? We need these people-centered and holistic strategies. We need to start with good local data to explain the reasons for low uptake, and we need to measure across the 4 domains that I described. We need to be thinking about this from a behavioral perspective, because sometimes people know that vaccination is important. Sometimes they're planning to, but sometimes it's just too difficult. There are other things that get in the way. Then also supporting our health workers is also absolutely critical. Making sure they're well trained, well supported, and really able to respond to these questions and concerns from within the community. Engaging these community representatives who can promote vaccination and promote the norms that most people in the village are getting vaccinated, all these things that help ensure there's a positive social setting for vaccination is really critical. And that we are continuing to deliver effective, trusted communications through the right sources, and that we partner. That I think COVID has given us so many opportunities for thinking about partnerships to promote vaccination beyond the health sector, even thinking about the social services, or even other groups like sports or the education sector who can be involved in promoting vaccination as well. And a lot of these things can help promote health literacy and scientific literacy in general, so that people really understand the benefits and importance of vaccination as a foundation. And lastly, promoting political commitment to investing in all of these necessary strategies, in supporting our health workers, in sharing accurate information, and really designing these tailored and targeted strategies to make vaccination as easy and convenient and accessible as possible. So a lot of our work that we've done over the last couple of years is summarized in a WHO position paper. And this reflects WHO's global policy position on behavioral and social drivers of vaccine uptake. And it summarizes all of the evidence and the testing and validation tools, testing and validation process that led us to the finalization of our tools and guidance and our indicators on the behavioral and social drivers. And it also adds more detail on the findings of our review that identified the effective interventions, and it has recommendations about the use of these tools and future research directions. So this is also an important reference, particularly for any local advocacy and support for decision-making and planning, where we really need to be promoting the importance of having and using this local data. And lastly, just to summarize, here's, I think, my final slide to recap on the main tools and guidance that I've mentioned throughout this presentation. So firstly, our position paper with the recommendations, the tools and guidance, and that's for COVID and childhood vaccination, the survey, the qualitative guides, and the how-to, and these other 2 guides as well on quality services and the closing gaps approach for tailoring immunization programs. That's that community-centered approach as well. So with this, you should have almost an entire kit to then be able to go back and really think about how these things can be used in your local setting to give you a very user-friendly head start in having the tools and templates and resources to start thinking about how to understand and overcome these gaps in coverage. So I'll leave it there, and we can go into any questions, and I could take any questions from the chat or from the audience. And I also just want to say thank you very, very much for this session and your attention. And I really look forward to any follow-up from here as well. So thank you very much.
Huge thank you, Lisa. I think there's the chat has been very active, and I think people are very appreciative of this presentation, and a lot of people have said how useful this will be for their work and how they recognize that we have to really rethink how we communicate about immunization. So I think you certainly have got the message across loud and clear, and I think it's really important. And somebody wants to see the recommendations and the tools again online, if you can put those up, but otherwise all the information will be shared at the end. So just firstly, I'd like to just, there's a lot of chatter going on about infodemics. So could you just explain or expand a bit more about that? Because I think for some people, they're aware of the open WHO training that's available, and there's also a lot more things happening at the moment. So it'd be great if you could just expand on that a little bit.
Yes, excellent question. Thank you, Laura. And thanks to people who raised this topic, because absolutely there's been a lot of attention on the concept of an infodemic. So an infodemic is essentially an excess of information on a certain topic. And as we have seen during COVID, ever since the beginning in COVID, there's been so much, like a flood of information where people have tried to explain what is COVID and what does the disease look like? How do you prevent it? What are the symptoms? How can you avoid getting it? And then also for the vaccines as well. And it's almost as if there's been this total saturation of information on the information about COVID, for example. But this can also take place on any health emergency. And maybe there's a little bit of that right now also when it comes to monkeypox. If you look at the health media and health journalism today, there's a lot of attention on monkeypox, but maybe not to the same extent as for COVID, given it was a huge pandemic that essentially shut down the world. So an infodemic is, in short, this excess saturation of information on the topic of COVID or any other issue. And the important thing is that the infodemic can be accurate and misinformation as well. So it can be accurate information, correct information that is being circulated by reputable, trusted, accurate sources, scientific institutions, medical institutions, and experts. There can also be misinformation, and there can also be disinformation. And misinformation is like rumors. It's where there's just a lot of inaccurate information about a topic. Like, for example, you can get COVID by touching something, or for example, you can, the vaccines contain bad ingredients. Maybe people just thought that the vaccines were being developed very, very quickly, and so there were shortcuts and people thought there were bad ingredients getting into the vaccines. That's misinformation, these kinds of rumors. And disinformation is actually where inaccurate information, wrong information is being deliberately, circulated widely to serve the interests of certain groups. And it's almost as if it's like propaganda, actually. Now, there's been a lot of attention on infodemics over the last couple of years because of the saturation we've seen. And we live in this digital information environment. So it is so easy for people to be sharing information using their phones, using apps on Facebook, Twitter, WhatsApp, Telegraph, so many other ways in which information now immediately spreads anywhere in the world. And so the concept of the infodemic is not only about the saturation, but the speed of information travel everywhere. So there has been a lot of attention on this. And the way to respond to the infodemic is essentially the same as what I described for responding to misinformation. The infodemic is just the phenomenon of this saturation of information and excess information, whether it's right or wrong. But when we're thinking about misinformation or even disinformation specifically, this is where we need to be listening. Where is it coming from? On what topic? Who's sharing it? Why are they sharing it? Who's seeing it? What is the level of exposure to this misinformation as well? Is it just really confined to a little bubble of people who are sharing it within their own little bubble, their own little community? Or has it just gone across the entire country and beyond? Has everyone seen this? Because it's now been on radio. Someone talked about this on radio. So we need to answer these kinds of questions when we're assessing the infodemic, and particularly thinking about all of the misinformation and saying how far, who is spreading it, who is seeing it, what is it about, and then how do we respond? Now, like I said, information is important, but it's not enough for us to get vaccinated. So we're also seeing, when we have excellent data and evidence, that the misinformation or even correct information is not always impacting actual behaviors. What the factors that impact actual vaccination behaviors are these social influences, and even more importantly, the practical issues, making vaccinations so easy and convenient to access and combining it with local trusted representatives. Those are the things that really will get people vaccinated. So information is an important part, and it's really necessary to make information available so that we answer people's questions and they can find accurate information if they're looking for it. But that alone is not going to be enough to ultimately get people vaccinated. And we need all of these supportive social influences, and we need these quality services that are close to the community and really meeting local community needs. That's what gets people vaccinated at the end of the day.
Thank you, Lisa, for that response. A related question from Dr. Juiska. The question is, how is it possible to stop misinformation with social media, using social media?
Yeah, thank you very much. So that's also a good question. How do we stop it? So sometimes it's impossible to stop. Let's face it, that when people are sharing misinformation through different kinds of channels, it can be very difficult to stop. But there are some things that we can do, and that was described on my slide. So the first thing is to, in brief, make sure people know how to look for accurate information. Make sure people know to trust the source and check the accuracy of the information they're accessing. So this is kind of like a digital literacy skill, that people know who to trust for accurate information. And if people know who to trust, then they will check the source, and maybe they will not share the information further to other friends or family. They will look at some information and go, I'm not sure about that. Let me check where it came from. That doesn't look really accurate. And if people have these good digital literacy skills, they will be like, no, I'm not going to share that. I'm not going to forward that on. I checked and I know that's wrong. So that's one thing that people can do to stop the spread of misinformation. And another thing that people can be doing is actually making sure that there's accurate information easily available even before any of the misinformation gets out. And this is where we can apply the same principles of vaccination to information spread. And what we need to be doing is making sure that our scientific authorities and medical institutions and other trusted sources are the first to share accurate information about a disease and the vaccines. And in this way, when people first see accurate information and they know that it comes from a trusted source, then when they see the misinformation, they will be like, hang on, I already know that, vaccines contain safe ingredients. I know that these vaccines were developed and this is, all these things, etc. So in that way, people already have this knowledge and understanding about what's accurate, so that when it comes to when they might see misinformation, then they kind of go, no, I saw this, but I already know that this is what's accurate. And I'm not really sure even the source of where this is coming from. So that's also another way of being able to stay ahead. And immunization programs and other scientific authorities need to really be doing this listening and being the first to share accurate information through these trusted sources as well. So that's another way in which to stop the spread of misinformation. And again, reiterating that information is only one small part of what it takes to get people vaccinated. And I know it's a really worrying, concerning topic, and it can really feel very unfair when there's all this wrong information out there. I absolutely understand that, but know that in addition to listening and staying ahead of the misinformation and trying to keep a positive, accurate information environment, there are so many other things we need to be doing at the same time that help get people vaccinated and make sure that vaccination is so convenient, easy to access and afford, that it's almost so appealing, it's impossible to refuse. So all of these other strategies related to the service design and the social influences that support vaccination are really almost so much more important and critical, in addition to the point about having accurate information available.
Hello, Lisa. So for the next question, I'm actually going to combine 2 points here. First was a comment made that hesitancy commences with health workers before the community. Let us start with the health workers in charge of immunization. So you've already alluded to this in your presentation, but it's, hoping you could expand a little bit more about strategies for health workers. And in addition, there was a question of how can we stop the spread of misinformation originating from religious leaders who have a number of followers. So similar question, but different target group here for maybe religious leaders. Hoping we could tackle both of those here.
Okay. Yeah, thank you. Some great questions. And this is also something that in immunization programs we're not always, it's sometimes discouraging to think that there are health workers that would not support vaccination, when we know they should be the ones who have the knowledge and the training and the support to promote and support vaccination. But it's also true that in some settings, health workers are missing out, and they're missing out that support from within the system. And maybe they have certain questions and concerns that relate to other underlying factors. Maybe in some settings, they don't feel like they are fairly paid and remunerated. Maybe in some settings, they feel like they haven't been trained for a long time, and there are certain questions that they're starting to ask at the back of their mind. Maybe also in some settings, they don't feel like they trust the authorities in a country. So there's also a variety of reasons that are unique that can explain why health workers themselves might be hesitant. But the solution is the same as what I've described in this presentation. And we can use the same tools with the same framework, with the 4 domains and the same processes. So we can be thinking about those 4 domains: the thinking and feeling, the social processes, motivation, and the practical factors. Use that to gather data to understand why health workers are hesitant. And from there to say, okay, how do we work together? Let's have some conversations with health workers and say, what would it take to bring you towards a decision to accept vaccination? And the last thing is to say, let's not assume why health workers may be hesitant, because over the last year or so, there are settings where we've seen excellent data gathered to understand why health workers are hesitant. And a lot of that data in some settings has shown that the vaccination has not been easy and convenient for health workers as well. And that's surprising, because you would think that vaccination would be maybe available where they work. But for COVID vaccines, maybe the health workers themselves also have to travel far, pay a large cost to get to that health centre. And maybe they have been working nonstop themselves as health workers supporting their community, and they are really just exhausted and overwhelmed and super busy in their day-to-day life. So let's also be very understanding and empathetic about health workers, and again, follow the same process of saying why and what do we do about it, and not make any assumptions. So that's what I would say about hesitancy in health workers. And it's a similar thing for religious leaders as well, that it's also about having conversations with religious leaders and saying, so tell me about your concerns. And again, very broad, open questions. And again, to really understand why they have these underlying questions and concerns, what's holding them back, why are they not supportive, and what they can do next to help bring people towards a vaccination, and different ways in which other community members, authorities, other religious leaders, maybe there are other religious leaders from the same religious group who do support vaccination. So, but that first conversation and gathering that data, the open conversation, the understanding will give us a hint and directions for the steps to take.
Wonderful. Thanks so much, Lisa. And I know we've gotten a number of additional questions and comments in the chat, which we've all been making a note of. And again, we'll send a Q&A document after the session. But since we're running short on time, I'm going to go ahead and close out. First, just letting you know that we will be posting a reflection question to the Boost Learning Group forum. So which part of the session will be most relevant in your work ahead? And then what would you do differently now to better understand and address low uptake? Again, we'll be reviewing your responses and reporting out during next week's session. Next slide, please. And this just notes the upcoming live engagement topics. We have 3 sessions to go, and the next session will be on publishing your results, scientific writing, and developing case studies. Next slide. And then just a few steps to continue today's conversation. Again, we request that you do take our post-session survey, and we've shared a link in the chat. You can also follow up and continue the conversation with your colleagues, as well as access the resources from today's session through the Boost Learning Group and our Telegram channel. So again, we've provided a few links for you to join us on those platforms. And as a reminder, you will receive a certificate of completion if you attend all of our sessions, and also fill out that post-session survey after each session. Next slide. And then last but not least, I just wanted to note a few upcoming Boost events and learning opportunities. So if you haven't already, I encourage you to join our Behavioral Science Immunization Network. We have an event coming up next week on June 14th. And if you subscribe to that learning group on the Boost platform, you'll receive details about that event. We also are launching a new course at the end of this month on gender and immunization opportunities for action. The deadline to apply for that course is June 15th. So again, would encourage you to check out more information on that course. And again, we're circulating that in the chat, and we'll also send information via email after the session ends. And then last but not least, we're excited to present another cohort of our Storytelling for Change course. This is a 5-week self-paced course that's offered through your mobile phone. And we're excited to also launch a cohort in French. So we'll have more details in the coming weeks, but we invite you to join us for that course. And with that, I just want to go ahead and thank Lisa again for her excellent facilitation of today's session. And as always, I want to thank all of our participants for being so active in the chat and asking really great questions. And I think that's it from my side. So thank you again, and we look forward to seeing you next week. Have a great day.